Indian Council for Medical Research short-term studentship pilot study on the study of oral ketoconazole versus ketoconazole soap in TINEA VERSICOLOR, an open clinical trial. I am an undergraduate student at Kasturba Medical College, India. Let me introduce this to you the same way I did it to all my potential research subjects. What? TINEA versicolor, also known as Ptariasis versicolor, is a superficial fungal infection of the skin caused by Malassezia furfur. Why? Hyperhidrosis, diabetes mellitus, steroids, cancer chemotherapy, malnutrition, usage of oral contraceptive pills, and other systemic conditions that lead to decreased immunity transform these yeast forms to mycelial pathogenic forms, where these present as typical scaly macules as hyper and hypopigmented lesions commonly on shoulders, back, chest, and neck and folds of the skin. What exactly is happening here? In 1990, ketoconazole and imidazole derivative, a broad-spectrum antifungal, was successfully stated to be used in the treatment of TINEA versicolor as oral therapy. Oral therapy, though sufficient and convenient and effective, does not produce long-lasting effects. It is generally reserved for recalcitrant causes and extensive involvement and contraindicated in hepatitis and other systemic disorders. And then ketoconazole was therefore introduced as topical creams, lotion therapies, but again limited success because of compromised compliance. Why? Odor, messy, large inaccessible areas, and therefore decreased compliance. And then they thought, why not introduce this into something in a daily regimen, like a daily routine, say bathing, assuming all of us have bath daily, and then ketoconazole soaps came into the market. And therefore, we proceed with the aims and objectives to compare the efficacy of topical ketoconazole soap and oral ketoconazole therapy, to assess the reliability of ketoconazole soap alone as a mainstay of therapy. The patients and methods. 12 patients who reported to the dermatology department of Kasturba Hospital, Manipal in the prevalent known seasons of May and June successfully completed the study under the study criteria, which is exclusion criteria: previous oral therapy for the past 4 weeks, topical therapy for the previous 2 weeks, known history of chronic liver diseases, known hypersensitivity to ketoconazole, patients less than 14 years of age, pregnant lactating women, and patients not willing for the study, obviously. And the inclusion criteria, which are typically clinical picture of macules with fine scales, and the diagnosis of TINEA versicolor confirmed by potassium hydroxide mount, by the characteristic spaghetti and meatball appearance, or in India, which we lovingly refer to as gulab jamun and vermicelli. The diagnosis was therefore confirmed, consent taken, and index lesion photograph and clinical assessment was done on the parameters of erythema, scaling, and pruritus on a scale of 0, 1, 2, 3, which is absent, mild, moderate, and severe respectively. Sorry about that. By block randomization, the patients were thrown into group 1 or group 2. The group 1 being the oral 400 mg stat ketoconazole and a standard non-medicated soap was given to be used for a period of 1 month and were asked to come back after 4 weeks. In group 2, the topical soap therapy, they were advised to use the soap 3 minutes and leave the lather for 3 minutes once daily, and a follow-up call was made after 15 days, and a global assessment after 4 weeks was done. After analysis, the observation and results, what we saw, what I would like to observe here is the number of patients that move towards the lower grades, that is the 0, prior and post therapy. You would see the numbers increasing in the level of in the grade 0 after they took the therapy. Mycological evaluation and clinical evaluation was done, and the 66% of patients in the oral therapy and 34% in topical soap therapy did have a negative KOH. And in clinical evaluation, there were 5 responders in each group, In the oral group, they were 66% healed disease, 1 residual disease, and 1 no change. In the topical soap therapy, we had 2 people, that is 34% with healed disease, 50% with residual disease, and 1%, 17% with no disease. These patients were coincidentally diabetic mellitus and therefore possibly immunocompromised. Therefore, on evaluating in general the global assessment, mycological and clinical cure, we had about 36% of patients in topical soap therapy who were cured and 64% of oral patients who were cured. Therefore, we suggest that the efficacy of oral ketoconazole is better to that of topical soap ketoconazole in the treatment of tinea versicolor. If you compare the different studies that have compared the oral ketoconazole, we were very close in comparison to other studies with an efficacy of 66%, especially with the single dose studies. In topical studies, however, we had a very low cure rate, that is about 34%. But we taken into consideration the studies who have compared both the oral and the topical therapy. Oral we had more or less the same or a bit less, but in topical soap therapy it was a bit decreased. This is because might be due to the single dose of oral ketoconazole used and the shorter duration of contact with the ketoconazole soap, which was just for a period of 3 minutes. There were no side effects noticed in the oral ketoconazole group, and maybe the adverse of ketoconazole have usually been recorded after a long course of therapy, generally more than a month. The limitations of the study was because of the small sample size and the large number of dropouts. There was no calculation of long-term relapse rate. The conclusions which we derived from the study are efficacy of oral ketoconazole is better than topical soap ketoconazole, though improved compliance was seen with soap as bathing is a daily ritual. The reliability of soap as a mainstay is not established. Ketoconazole soap can be suggested as an adjuvant and probably be used for prophylaxis in patients with recurrent tinea versicolor, which is a characteristic recurrent infection. These are my references, and I would like to thank ICMR, my dean, my parents, and my
Thank you for your presentation.
Thank you.
In the first table of the results, you compare between both, the two groups, those who use the soap and the other two. But I didn't know what statistical test did you use? The first table.
When we took the erythema scaling pruritus. This one?
No, comparison between the two groups. First one. First one. Yeah. What kind of statistical test did you use?
We used the SPSS statistical package.
How did you compare between both groups?
After we analyzed our results, we had percentages for my study. Therefore, when we take the abstract of the previous studies we were done and put their percentages, and then we could assess how close we were or how far we were from the results of the previous studies done.
I mean, this must be clear in this the table. What's the level of significance? What statistical test did you use? It must be clear. Did you do your statistical analysis yourself, or someone else?
I did do it with the assistance of the statistical department in the university.
Okay, but this must be clear in the table.
Yes.
Okay.
Thank you.
I would like to ask you, what is the routine standard treatment for tinea versicolor?
There is no standard protocol that is being followed in the hospital right now.
Not in the hospital. In standard treatment, what should it be?
They do not use ketoconazole anymore. They use fluconazole which are the more latest generation of drugs. But incidentally, we had only ketoconazole given in the form of soap. Therefore, we had to compromise on the oral 1, 2 and related.
Why did you give such a low dose? One dose only?
It is a standard, ma'am. It is
1 month? All the other studies use different doses per day, 200 milligrams per day.
No,
This single dose is what, for per day?
just once.
Once.
Yes,
Why
ma'am.
did you do such a small?
It is a standard, ma'am. Even Harrison's internal medicine does say it is as a
Just standard. One dose is enough to cure?
Yes, ma'am. 400 mg is a standard.
Alright. Why is there such a small sample size?
That's actually a lovely question, ma'am. When the ethics department, when the ethics committee asked me the question, what would you do if a person with 15% body surface area involvement of tinea versicolor comes to you, and the block randomization says you should put him in the topical group? He actually deserves an oral thing.
Why should he deserve?
Because systemic involvement, generally oral therapy has to be given rather than a topical.
You have to have the same inclusion criteria from the beginning.
Yes, ma'am. Block randomization will divide unbiased into one of these groups. But it was a good thing. I would answer them telling tinea versicolor is asymptomatic disease, maybe mild pruritus or just maybe little cosmetic disfigurement. But what happened was when all the patients did not report to 15% body surface area. They were people with 1%, 0.5%. And then these patients, when they came and then we included them in the study, they went back and they never came back because it is a negligible disease. It doesn't matter they came back or not.
So what was the dropout rate? What was the dropout rate? What was the dropout rate? How many dropouts?
I must admit that it was a 2-month based study, but I carried out for a period of 7 months. I had more than 80% dropouts.
How many did you recruit?
50.
You recruited 50. All right. Okay, thank you.
If I could say one thing more, we have so many advancements made, new antibiotics discovered, but we don't, when now also we have bacterial resistance developing. So we go back to the prophylaxis, the prevention methods. When you take tinea versicolor in the same way, you keep this thing in mind and you take tinea versicolor, you wonder if you go back to the preventive and the prophylactic methods and introduce them into the normal daily regimen, will it help? We try to answer that question also. Thank you so much. Namaste.
You divide erythema scaling on some international scale, or have you done it according to your own scale?
No, we did take into the previous studies who use this particular scales, and these are the only symptoms which the patients who report to the hospital present with.
Okay.
Yes.
So is it a WHO scale, or which study have you you have chosen scale from the which study?
In my references, the first study done by Dr. V.K. Jain and Kumar Agarwal, I actually wrote a letter to them asking whether I could use for this.
Okay.
They did say yes, and then I went to see.
Okay. Thank you.
Thank you so much.
Thank you very much.